Hello, I would like to discuss the potential associations between the socioeconomic background and eye disease on two examples. The major example is the recently performed Ural eye and medical study. It was performed in the city of Ufa, which is the capital of the Republic of Bashkortostan at the border between Europe and Asia. It was performed by Professor Mukharram Bikbov from the Ufa Eye Research Institute and his team. It was performed in a rural region and in an urban region. The inclusion criteria were an age of 40+ years and living in the study regions, as I said, a part of the city of Ufa, and a rural region, a village area about 65 kilometers outside of Ufa. Out of 7,300 eligible individuals, about 6,000 or 80% participated with a mean age of 59 years. The composition of the study population was similar to the one of the Russian general population, and the study participants underwent a detailed interview and an ophthalmological and internal medical examination. The interview consisted of about 250 questions, such as the history of internal medical diseases and pain and tumbling. It included questions on the diet, as shown in the slide, and on smoking. It included questions on the alcohol consumption and on physical activity. Also, hearing loss was assessed by asking specific questions about the subjective hearing loss. The depression score was evaluated, and also the state of anxiety using standardized questionnaires. The socioeconomic background was assessed by questions on the family structure, ethnicity, and religion, and mainly by the level of education and the other questions listed here. We also asked for the history of previous ocular disorders and surgeries and positive family history of eye diseases. The questionnaire also included questions on dry eye. The ophthalmological examination included a whole series of assessments, including refractometry, tonometry, slit lamp biomorphometry, photography of the lens, optic disc, and macula, and also OCT. The clinical internal medical examination included blood pressure measurement, assessment of body weight, height, waist, and hip circumference, spirometry for the assessment of chronic obstructive pulmonary disease, hand grip dynamometry, electrocardiography, and biochemical examination of fasting blood samples, assessing these parameters. The composition of the study population, as I said before, was roughly similar to the Russian population. It showed two constrictions in the birth groups of 40 to 45 and 62 to 70, mainly caused by the consequences of World War II. You see here also body-wide, the anthropomorphic parameters. The level of education was stratified into several degrees, and the mean degree decreased with higher age. Let's start with the general parameter, blood pressure. 87% of the whole study population showed either elevated blood pressure or hypertension using the new definition by the American Cardiological Society. The blood pressure increased with age. And in the multivariate analysis, it was associated with lower educational level. Higher blood pressure correlated with lower educational level after adjusting for age, gender, region of location, region of habitation, and the other parameters. Coming to ocular parameters, cataract present as type of any cataract in 44% of the population, that was relatively high, was associated in the multivariate analysis with a lower educational level. Axial length, as expected, correlated with a higher level of education, again in the multivariate analysis. Here we see the graph with longer axial length up to about 26 millimeters. The level of education increases, but then interestingly, it decreases. Correspondingly, the prevalence of myopic maculopathy with a prevalence of 1.3% for any stage of myopic maculopathy in the population was not related to the level of education in the multivariate analysis. Pterygium, showing an age association, was correlated with a lower level of education in the multivariate analysis. And finally, the prevalence of vision impairment was associated with older age, higher prevalence of diabetes, longer axial length, and a lower educational level in the multivariate analysis. Intraocular pressure, we see here the distribution, was correlated with a number of parameters, but not with the level of education. Pseudoexfoliation, strongly correlating with age, was associated, in addition, with Russian ethnicity, a higher prevalence of open-angle glaucoma and intraocular pressure, but not with the level of education. AMD, we see here the prevalence figures for early, intermediate, and late AMD, was not related with level of education. And also glaucoma, or glaucoma as a whole and open angle and angle closure glaucoma differentiated separately, were correlated with age, but not with the level of education. Interestingly, it was estimated with the estimated translaminar cribrosa pressure difference. Hearing loss, as another sensory loss, also was not related with the level of education in the multivariate analysis. Similar results were found in the Beijing eye study, in which a higher level of education was associated with more myopic refractive error or longer axial length, a higher best-corrected visual acuity, lower degree of nuclear cataract, and a lower prevalence of angle closure glaucoma, finding what we had not found in our study, but the number of patients with angle closure glaucoma was in the Ural study lower than in the Beijing eye study, so that might have been the reason. So that in conclusion, in multivariate analysis, a higher level of education or a higher socioeconomic background was associated with longer axial length, a lower prevalence of pterygium and nuclear cataract, and a lower prevalence of moderate to severe vision impairment, in addition to a lower blood pressure. It was not related to intraocular pressure, pseudoexfoliation, AMD, glaucoma, hearing loss, and also it was not correlated to the prevalence of myopic maculopathy. In general, the relationship between the socioeconomic background or level of education and the prevalence and severity of eye diseases may depend on primary associations between the level of education and the risk factors, such as axial length for the disease. And if the disease can be cured, such as cataract, it will also depend on the accessibility of the medical infrastructure for all socioeconomic groups. Thank you very much.